Good morning, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with the Base Hospital Program. Thanks for joining us for another webinar. We are presenting today on diabetes. Just a quick review for you guys. Happy Halloween, I should say. Presenting today, we have Dwayne Cottel, Regional Paramedic Educator, Tracy Gaunt, also Regional Paramedic Educator, and Dr. Don Eby, Local Medical Director. If you're new to webinar, there's a couple ways that we can communicate. You have the option to ask some questions in the question box at the bottom of your control panel. So you can type questions in that way, and feel free to do that throughout the presentation. If a question comes up where I feel like the audience would benefit from the answer, then I'll chime in and make that question sort of live for everyone to hear. You also have the option to raise your hand. You'll see a little hand icon on the control panel, and if you click on that, I'll be able to see that you've raised your hand, and if you have a microphone, you can actually ask the question live. We typically like to keep those to the end of the presentation, but if you've got something urgent, maybe type me a note in the question box, and we'll bring up that question for you. Once again, thank you for joining us, and I will hand the presentation over to Don, Tracy, and Dwayne.
Thank you, Stephanie. Once again, good morning and welcome. Part of our learning objectives then for the paramedic with the diabetic review is to describe the anatomy and physiology of the pancreas, describe the effects of hormones on the maintenance of normal glucose metabolism, compare the various diabetic emergencies and their corresponding signs and symptoms, and apply the current medical directives appropriately to various diabetic emergencies. This presentation will review pathophysiology. We'll provide an overview of hypoglycemia, an overview of hypoglycemia. We'll talk about 2 case studies. We will review the medical directives pertaining to hypoglycemia. So to start, case 1, we have a 25-year-old male, insulin-dependent diabetic found by the family confused with a decreased LOA. EMS arrival, they find the family states the patient is hypoglycemic. The blood glucose is 3. All the vitals are stable with a GCS of 13. For case 2, we have a 65-year-old female, insulin-dependent diabetic, found by the family confused with a decreased LOA. EMS arrive and find the family states the patient is a diabetic. Their blood glucose on this patient is 1. All vitals are stable with a GCS of 13. So Dwayne now is going to take us through some pathophysiology.
Okay, everybody. So we'll just talk a little bit about the pancreas itself, one of our main player here for our diabetics. So the pancreas itself, longer organ, is located retroperitoneal. And we think about what the pancreas does. So pancreas makes insulin as well as makes glucagon. It also has a role in absorption and the use of fats, carbohydrates, and proteins. And with the glucagon being made in the pancreas, it has a role in controlling our normal blood glucose levels in the circulating blood glucose levels. It also has the other endocrine and exocrine functions as far as different types of enzymes are being secreted to aid with digestion and other things. So as we look, carry on here to the next slide, where is insulin made? So in the islets of Langerhans, the beta cells of the islets of Langerhans. And on average, in the average adult, there's about 0.6 units per kilogram per day made of insulin. The alpha cells, they make and secrete glucagon, which is subsequently stored in the liver. And the nerve bundles from both the autonomic nervous system, both divisions from the autonomic nervous system, rather, innervate the pancreatic islets. So as we continue forward here to the next slide, when we talk about insulin and glucagon, and we're looking at how it's controlled, it's sort of like a teeter-totter. Okay, in response to high sugar levels, high circulating blood glucose levels, insulin will be released because glucose is too big of an element on its own to get into the brain cells. So with that, insulin is released, and it basically kind of it facilitates the glucose into the cells. Okay, the glucagon itself is released from the liver when blood glucose levels fall. Okay, alpha cells in the pancreas make the glucagon, however it is stored in the liver, and when blood glucose levels do fall, glucagon is made, is secreted, and we're going to talk about glucogenolysis and gluconeogenesis in a next upcoming slide. So those are the two basic functions of insulin and glucagon. So if we can continue on here to the next. Okay, so glucogenolysis and gluconeogenesis. Glucogenolysis is the conversion of glycogen to glucose, and as in response to low sugar levels, this happens all the time. Our bodies are constantly trying to maintain homeostasis, this constant check and balance. So the glucagon, which is stored in the liver, is converted to glycogen in response to low circulating blood sugar levels. And then once that glycogen is released into the bloodstream, it's converted to glucose, utilized for energy, because the brain cells require a constant supply of oxygen and sugar. Now conversely, with gluconeogenesis, when all of our stores are gone, everything's gone out of our bloodstream, our glycogen, glucagon stores, they've been depleted, totally depleted, then what happens is, with gluconeogenesis, the body starts to break down other forms or other elements in order to maintain energy or to create energy, which it doesn't do. And as a result of that, fats and proteins will break down and ketone bodies will build up. So as we move forward here, so in normal digestion, person is non-diabetic, so food is eaten, digestion begins in the stomach. Those simple sugars are then broken down in the small intestine, absorbed in the small intestine into the bloodstream. When they enter that bloodstream, insulin is released by the pancreas as a response to high blood sugar levels. Insulin then carries that glucose, breaks it down. It's too big of an element on its own. We talked about that before. And then goes into the cell, and then the patient has energy and everything is good and homeostatic balance is maintained. So when we talk about diabetes mellitus, there's two different types essentially. So our type 1 or our juvenile onset diabetes, the pancreas is only it's usually not working, so the patient requires a constant supply of insulin, either a pump or by injection. Type 2, usually called mature onset diabetes, the insulin receptor cells and the glucose receptor cells become desensitized, and there's not a lot of insulin production. The pancreas is still working, it's just not working at 100%. This usually happens later on in years. So you'll see this type 2, the ones that are on the oral type medications to maintain their normal blood glucose levels. So when we talk about the pathophysiology of our diabetics there, you know, the sugar doesn't enter the body cells. The patient ends up feeling tired and weak. Okay, you know, the simple sugars are broken down in the small intestine, and they try to enter the bloodstream, but they're just not getting there. They're just not getting there. The sugar's being chewed up very, very quickly. So carrying on. So as we kind of reviewed already, so our type 1 diabetics are insulin dependent, known as juvenile onset, happens very young, in utero, little or no insulin is released by that pancreas. Beta cells have been destroyed, like by body's own immune system, or some type of pathogen has gotten in there, and we discussed that the patient needs constant supply of insulin, either by injection or by insulin pumps, so to speak. Type 2, the primary problem is less sensitivity to insulin. It affects less insulin is released. Usually type 2 diabetes or type 2 diabetics are associated with obesity, decrease in the insulin receptor sites, decrease in glucose utilization. Most of the time, what they take in these oral medications, it is controlled with diet, exercise, and medication, and they lead a normal, healthy lifestyle, and everything is usually pretty good. So, which brings us to, it's not really a type, but it's a condition that some people end up in, gestational diabetes. So, only happens with females. Okay, develops during pregnancy. Okay, it's often treated with insulin. Usually disappears post-delivery. May remain on as type 2, and sometimes it will require a little bit of insulin after the fact, just to keep their balance in check, their homeostasis in check with their sugar and their insulin levels. We don't know why this happens. It's not 100% clear. We just know that it does happen, and these babies of gestational diabetic moms tend to be very, very large. Last diabetes is around 11 to 14 pounds large, so very, very big infants. But babies usually deliver with no problem and healthy, and then, as I said, post-delivery may have to have some insulin post-delivery just to kind of get things back, get the pancreas working again. So we can move on here. So management.
Sorry, Dr. Eby is going to now take us through the management of diabetics.
Okay, thanks, Tracy and Dwayne, or Dwayne, I should say. I'm sorry. The reason that we're so interested in treating diabetics is mostly because of the potential complications that occur when diabetes isn't treated, and these can be divided really into about three things. I mean, with high blood sugars, on a long-term basis, it increases the risk of developing atherosclerosis. And this can affect either the arteries in the heart, so people who are diabetic are at increased risk of developing atherosclerotic heart disease and therefore MIs, chest pain, congestive heart failure, those sorts of complications that come from that. Kidney failure, which can be, again, a very significant and costly complication, and infections. And the infections can be a problem often to manage, especially when they're related to peripheral vascular disease. So often diabetics will have, again, because of the increased atherosclerosis that they develop, it tends to affect the small vessels, and so the blood supply then to the limbs becomes less, and the combination of poor blood supply and the sugar makes them more susceptible to infections with their chronically poor blood flow to the limbs. And so these become a big problem, and as we sort of hear in the press every day, diabetes is becoming more of a problem, and as we move our demographic into an aging population, we're going to have more diabetics to deal with. So there really is, I like to think of this as basically it's a balance, and as it's easy to understand if you think about it as a balance. We try, and the body tries to maintain the blood sugar at a sort of constant small range, and if it gets too high, then there's a series of things that happen, which Dwayne has taken you through, to try and bring it back into balance. If it goes too low, the same thing happens. There's a series of mechanisms in the body that kick into play to try and bring the body back into the normal range. And it's when the pancreas fails that this mechanism of bringing the blood sugar back into the normal range also fails. And so there really are two portions to the management, and I'll just briefly go over the general management because that helps us understand sometimes how the emergency management of diabetes comes into play and when it becomes effective. So our principles for treating diabetics are essentially if you can maintain an ideal body weight. This helps to decrease the stress of the type 2 diabetics who, as they become more obese, they develop less insulin sensitivity, so therefore they need more insulin to be able to bring the blood sugars down. So that if you can maintain an ideal body weight, it reduces the amount of stress and helps the body to stay in that balance. So the other, and that's where exercise and other things to maintain body weight are important. The other thing is diet, which if you're suddenly presenting your body with a load of sugar, or you're asking the insulin or asking the pancreas to work really hard by either having large meals infrequently, then again this puts a stress on the pancreas, a stress on the body, and there's a difficulty in maintaining the balance. So once ideal body weight, if it can be achieved, and diet control doesn't control the blood sugar, then we move into a series of medications which can help. And the way that I like to think of it is when the pancreas is working but not really enough to keep the body in balance, then we try and treat them with generally oral hypoglycemics first. And there are multiple types of oral hypoglycemics. Usually you start with one. If that doesn't work, you either move to a second one, or some people are on multiple hypoglycemic drugs. Now, most common ones being things like metformin, glycoside. There's a whole series of them that you should be familiar with, or at least recognize the names of, because that cues you to the fact that this person is a diabetic. When oral hypoglycemics don't do aren't enough to maintain the body's blood sugar in the normal range, then we get into insulin replacement. And insulin replacement, again, can be extremely complicated, and you'll see a wide range from once daily dosing to multiple daily dosing to even continuous insulin pumps, which are being used by some people with the idea that you're trying to maintain the body's blood sugar in a narrow, in quotation marks, normal range. Now, the problem with tight control, or tightly trying to manage the blood sugar, is that sometimes these medications will overshoot and cause the person to become hypoglycemic. And that, as an emergency pre-hospital condition, is probably the condition that we face the most commonly. So, and the tighter the patient is trying to maintain their blood sugar, the greater the risk of them becoming hypoglycemic. And it's the hypoglycemia that produces the major problem. So as we move on, the two conditions that we are most interested in the pre-hospital setting are hypoglycemia and hyperglycemia, and these represent the two ends of the balance when it goes out of whack. So first of all, we're going to go and talk about hypoglycemia, because that certainly is the most important one and the one that people see most commonly. And what happens with hypoglycemia is that almost always there's a medication, for diabetic at any rate, there's a medication which is driving the blood sugar down. What will happen when the person becomes hypoglycemic is very similar to what happens in the body when a person hasn't eaten for a while, or other things and stresses, which so the blood sugar goes down, the body attempts to compensate. The pancreas is trying to push out glucagon to try and raise the blood sugar, but often the amount of medication that we've given people overwhelms the body's ability to do that, and there's no way that the body can compensate. And so they start to develop, or the person starts to develop symptoms. Now, on the slide, there's a whole list of symptoms that are possible. The important ones essentially are CNS alteration. So as the blood sugar starts to go down, the person starts to feel different. And often the most important thing that happens is the person will become irritable, they lose their sort of focus, their ability to concentrate, and often a diabetic will understand at that point that they are becoming hypoglycemic, and they'll do something about it. They'll have an extra snack or take some sweetened orange juice, for example, and attempt to do it. Sometimes this happens fairly quickly, or they ignore the symptoms, and when that happens, they start to become more and more sort of irritable, more and more confused, and then once they start to become confused, they don't recognize what's happening to them, and they just start down and become more and more, eventually they pass through confusion and they start becoming sleepy, potentially go into a coma. If nothing is reversed, they can seizure, and this is the patient that you will sometimes find non-responsive, and these are the ones that we need to do something about. But before you get to that point, they can have virtually any of the symptoms that are on the slide. So if we talk about management of hypoglycemia, obviously the first thing with any patient is to do a primary assessment and to try and figure out what's going on. And with all patients, especially ones with a decreased level of consciousness, you want to do the basic support things: airway, breathing, circulation, monitoring, and oxygen. And so for people with a decreased level of consciousness, the BLS standards say that they have to have oxygen put on them. And so these are the important first steps in the supportive management. But all of these people need a blood sugar exam done, because there's really no simple way that you can tell whether the slight confusion is low blood sugar or something else. But in people who are on diabetes medications, you have to assume that their blood sugars are low and to do a blood sugar examination. Okay, and then, we go back, if I could. Sorry, Stephanie. If the blood sugar is low, then you're left with treatment, which will be covered a little bit more fully later on in the webinar when we start talking specifically about the directives. But again, we need to replace the sugar because there's no simple way of raising the body is unable to raise the blood sugar, therefore it's low. So our options in the pre-hospital setting are to give them 50% dextrose in water. We can give them glucagon, or we can give them oral sugar if they're willing or if they're able to tolerate it. So that's basically our management of hypoglycemia in the pre-hospital setting.
Actually, Dawn, I'm going to jump in right there. There's a question from one of the medics online, and it falls nicely in what you were just saying. So the question is there a difference in following up with oral glucose if the patient has received either D50 or glucagon? So the question is more so related to, do we need to follow up with oral glucose if we've given D50, or is the answer different if we have given glucagon instead? What are your thoughts on that?
I don't think it matters whether you've given the person D50 or glucagon. I think it's reasonable to give the person some oral glucose once they have gotten back to a GCS of 15. Certainly, I think it's reasonable to do either. I think there's some debate about whether it's necessary or not, especially if the person comes back to a, they're wide awake, responsive, alert, and have a GCS of 15.
Great. I think that that probably answers it. Another one has actually popped up, which we could probably address at this time too, is could you possibly provide even just a brief explanation of how hypoglycemia might occur in a non-diabetic patient?
Well, it happens any time where the body's ability to raise its glucose becomes impaired. And so normally, as Dwayne had pointed out earlier, one of the sort of storage mechanisms that allows the body to push glucose out into the bloodstream fairly quickly is glycogen, which is stored in the liver. And so anytime somebody has impaired liver function, such as an alcoholic, or they have been used, or they've used up their glycogen stores, I should say, so in conditions of starvation, these sorts of things, you would be likely to find that the blood sugar would be low in a non-diabetic state. So those are things to consider, but generally those people tend to tolerate the low blood sugar reasonably well, and you don't get the more serious symptoms of hypoglycemia from those conditions. So I guess what I'm trying to say is that the alcoholic with cirrhosis might run a blood sugar of 3, and everybody has certainly seen cases like this where they've taken the blood sugar and you find that they've got a blood sugar of 2.5 or 3. It's probably reasonable to treat those people with oral glucose rather than glycogen, or sorry, not glycogen, but rather than glucagon or D50, because in those cases the glucagon, for example, is unlikely to raise the blood sugar significantly because there's no glycogen stores left, or at least there's little glycogen stores left to act upon. And as far as the D50 goes, I mean, again, it will be just a temporary fix because these people have essentially accommodated to having a lower blood sugar.
Perfect. Thanks, Don. That's all the questions that have come up so far.
Okay. The other end of the spectrum is high blood sugar. And on the slide, there's a series of potential symptoms that occur with hyperglycemia. So what happens again with hyperglycemia is, for a series of reasons, the pancreas isn't able to secrete enough insulin to handle the increased blood sugar that the person develops. And what happens in this situation is the blood sugar starts to increase. And the way the kidneys work are that the kidneys filter, obviously, your blood. They will filter out glucose, and as long as it's in a normal range, as it passes through the tubules, the glucose is reabsorbed back into the blood, and you don't end up with any glucose in the urine. Once the glucose, or the serum glucose level becomes high, the kidney isn't able to reabsorb all of the glucose that's filtered in the glomeruli, or the filtering part of the kidney, and it overwhelms the ability of the tubules then to reabsorb all of the glucose, and therefore the glucose starts to get dumped out in the urine. Well, glucose also will draw or keep fluid with it, because otherwise it would become super concentrated. So what happens is that the kidney can't absorb all the glucose that's being filtered by it. It draws fluid out, and then the person starts to develop symptoms of essentially dehydration. Before that happens, of course, they start to become thirsty, and so you'll find, people with hyperglycemia will often report that they have been drinking a lot, but they've also been peeing a lot or passing urine a lot because they need to pass the urine to get rid of the blood sugar. And again, this is a mechanism that the body has to try and bring down the blood sugar once it's reached a certain point. So a lot of then the mechanisms that occur are related to dehydration, and these are the things that are, and then with that you also will start to get changes in pH, the acidity in the body, and a whole series of physiologic changes occur. So it affects the electrolytes, the pH, and eventually, when all of these things get out of whack enough, the person becomes symptomatic. And if the blood sugar per se isn't usually the thing that causes the symptoms, it's the other things that go along with it, the dehydration and the changes in electrolytes, which cause most of the symptoms. And then the person runs into problems because they start to develop nausea, vomiting, sometimes abdominal pain, and then they're not able to even replace the fluids. And so paramedics will sometimes come upon people who are dehydrated, and they have become ill for one reason or another. Diabetics tend to stop taking their insulin or oral hypoglycemics when they become ill because they're afraid of their blood sugars going too low, and so then that compounds the problem. So they aren't able to bring their blood sugars down, and they get into this cycle. This usually happens much more slowly than hypoglycemia, and the changes are, again, essentially due to compensation, or the body attempting to compensate. So when it comes to treating hyperglycemia, again, the management of it is you have someone who may have a, what we would consider a diabetic emergency, the ketoacidosis that develops. The primary exam is, again, the basic supportive things, the airway, breathing, circulation. If they are if they're hypovolemic, then fluid is indicated. But generally, we try and replace fluid slowly. This condition didn't develop in a couple of hours. It usually develops over a series of days, and we try and correct the condition slowly. It's not like someone with a very low blood sugar, or sorry, very low blood pressure, that we try and give fluid too quickly, because again, if we give the fluid too quickly, then this causes the body to attempt to compensate for that, and it becomes difficult to manage. So we tend not to recommend large amounts of fluid right away, large being a relative thing. But if the person is hypoglycemic, or sorry, hypovolemic is what I meant to say, certainly then fluid boluses are indicated. But again, along with the supportive thing, airway, breathing, circulation, cardiac monitor, and oxygen if necessary. Now, if the person, often the person who is hyperglycemic will have a normal level of consciousness, and if their SaO2s are fine, they probably don't need supplemental oxygen in that case. So that's basically the pre-hospital management of hyperglycemia and hypoglycemia. So,
were there any questions before we go on into the medical directive?
Not at this point, Tracy.
Okay. Then thank you, Dr. Evie. Moving on, we're going to review the medical directive for hypoglycemia. Primary care paramedic may provide the treatment prescribed in this medical directive if certified and authorized. Indications then are agitation, altered LOA, or seizure, or symptoms of stroke. Conditions for dextrose: the patient needs to be greater than or equal to 2 years of age, have an altered LOA, and be hypoglycemic. To give glucagon, have an altered LOA, and be hypoglycemic. Contraindications for giving your dextrose: would be an allergy or sensitivity to your dextrose. And then the contraindications for glucagon, allergy or sensitivity to glucagon, or have the pheochromocytoma. To treat then for hypoglycemia, perform your blood sugar, administering your dextrose, glucagon, or oral glucose. As Dr. Evie said, the blood sugar needs to be less than 4 for adults or less than 3 for anyone under 2 years of age. Moving on then for the dosages, consider dextrose if certified and authorized. Dextrose, anyone greater than or equal to 2 years of age. It works out to 1 ml per kilo to a max single dose of 25 grams or 50 mils. You are able to give 2 doses of dextrose within a time frame of 10 minutes. For glucagon, there is no age. It works out to anyone less than 25 kilos gets the 0.5 milligrams of a max single dose, and another dose can be given 20 minutes later. For anyone over 25 kilos or greater than or equal to, you can give 1 milligram of glucagon and follow it up with a second dose if required 20 minutes later. The glucagon is to be given IM and the dextrose would be given IV. Some clinical considerations to think about with the medical directive for hypoglycemia. If the patient does respond to dextrose and glucagon, he or she, the patient, may receive oral glucose or other simple carbohydrates. If only mild symptoms or signs are exhibited, the patient may receive the oral glucose or other simple carbohydrates instead of the dextrose or glucagon. Once you have treated the patient, if the patient initiates an informed refusal of transport, a final set of vitals, including a blood sugar, must be attempted and documented. And dextrose is only given with paramedics who are certified in IV administration. Dwayne's going to take us through the 2 cases. We gave you the prelim for the cases at the beginning of the webinar, so Dwayne is going to take us through the cases and the treatment and have some discussion with them.
Okay, thank you, Tracy. So our first case here, people, 25-year-old diabetic, insulin-dependent diabetic male, found by his family, confused, decreased level of awareness. Family thinks that the patient is hypoglycemic. Crew gets there and checks his blood sugar, and 3.0 millimoles per liter. All vitals are stable, and decreased level awareness GCS of 13. So IV is established, and 25 grams of dextrose is given, IV push. Patient responds well to the treatment. Now his level of awareness is unaltered. He is tagged as a GCS of 15. Second blood sugar is done. It's 15.7 millimoles per liter a few minutes later. The vitals are still stable. So the patient refuses transport to the hospital and remains with the family at home.
All right, so following that case, we're actually going to launch a poll here to make this a little interactive for you. So you're going to see a poll up on your screen now. The question is, why should hypoglycemic patients be transported even if you've now raised their blood sugar to above 4? So imagine you've treated that patient and they're refusing, just as in case 1. Why should they be transported? I'm going to give you a couple minutes, or a couple seconds at least, to answer that. Okay, I'm going to close that poll. And so our results show that 100% of those of you who voted chose the first answer there. So there's a risk for recurring hypoglycemia. So we're going to cover that as we go through the case study here.
Okay, so looking at this, that patient, are they at risk for a recurrent hypoglycemic episode? Absolutely. You have to remember when we get there, we push that dextrose, there's an abnormally high level of insulin in there, and that's why their sugar has all been utilized, or the majority of it has been utilized. So these people are going to chew through that sugar pretty quick. Like, yes, it's 15 milli or 15.7 millimoles per liter post D50 administration. But you have to remember too, there's a few different factors. The one is, yes, their body's going to utilize that sugar very quickly. Okay, and that's why we always really tend to talk about, you know, eat after, especially if they are not going to be emerged. If they're adamantly refusal of service, they've met capacity, we have to ensure those things, that their sugar is normal, vitals are stable, and that they are eating some type of complex carbohydrate. The other factor is that, especially to do with these people with sliding scales of insulin, they will adjust their insulin administration according to their current sugar level. So say their normal sugar levels that they run are between 6 and 8, all of a sudden they're up at 16 after you leave, and they adjust their sliding scale accordingly, and then next thing you know, they've given themselves more insulin and they're right back into that state. Or worst case scenario, now they went into a cardiac arrest situation, which just gets very, very bad very ugly. So, but absolutely, you're 100% correct. They are at risk for recurrence of hypoglycemia. So we'll look at the next case here.
So before we actually move on to case 2, I've got a couple questions here for Dawn. First question, interesting one. So should you limit, or I guess could you limit the dose of D50 during administration if you're finding that the patient responds? So Dawn, I don't know what your take on that is, or what your thoughts are related to that.
Well, it's an interesting question and quite a reasonable one, actually. I think it would be possible to do that. However, I think the sort of standard of care is that we tend to give the full dose, and part of that is around what Dwayne was just talking about, is that if you give enough dextrose to reverse the symptoms, the problem is that the person still has the drugs on board that made them hypoglycemic. And so you may very well be able to give them enough dextrose and get enough dextrose into their bloodstream to reverse the symptoms. The question would then be, how long is that actually going to be maintained? Because in all likelihood, the hypoglycemics they have on board will continue to act, will continue to drive the blood sugar down, and they will really be at increased risk for hypoglycemia. So I guess the answer is theoretically yes. Practically speaking, it's a pretty thin line, and you just basically give the whole dose. I mean, there's no difficulty with having the blood sugar shoot up to 15 for an hour or so. That probably sometimes happens with most diabetics after they eat.
Great, thanks, Dawn. And one other question here is, what is the significance of changing the blood sugar level for pediatric versus the adult? So the pediatric patient, the requirement of blood sugar having to be less than 3 millimoles per liter versus the adult of 4.
So what's the significance of it?
Yeah, so the question here is, why is the peds blood sugar measured at less than 3 in order to treat, as opposed to the adult being less than 4?
Another good question. I think it's mostly because children, again, their blood sugars tend to be a little bit more erratic, especially on the low end, than adults. And so a blood sugar of 3 in a child or 3.5 in a child is not likely to be symptomatic, and I think it occurs far more frequently. The cutoff of 4 is an arbitrary point, so we had to decide on something, and the way the medical directives are constructed generally is that we're dealing with ranges of physiology, and it's just simply a cutoff point that then gives us, above this we do this, below this we do that.
Great, thanks, Don. So I think we can move on to case number 2 now.
Okay, so thank you, Don. So a 65-year-old insulin-dependent diabetic female found by their family, confused, altered LOA, decreased LOA, family states the patient is a diabetic. Assessment by the medic crew reveals a blood sugar of 1.0 millimoles per liter. Vitals are stable. They're tagging the patient with a Glycogenolysis scale of 12. So no ID is established, and they decide to use their glucagon. So 1 milligram of glucagon is given. So the patient responds well to the treatment. Glycogenolysis scale of 15 now. Second blood sugar of 4.7 millimoles per liter several minutes later, and vitals seem to be within normal parameters. So the patient refuses transport to the hospital and remains with the family at home. So we have patient given glucagon, post low blood sugar, and remaining with the family at home. So is this patient at risk for hypoglycemia again, considering the sugars only went up to about 4.7 millimoles per liter? And I think most of us would concur that yes, they probably will be. And these patients post glucagon administration, this is the patient where they've depleted their stores. Okay, now you're given the glucagon. Hopefully, some conversion has taken place. It has in this case, and they have woken up. So these are the people that it's paramount to get some food into them afterwards to sustain that blood glucose level. They are absolutely at risk. Don, do you have any comments on the post-glucagon administration?
Yeah, no, I think you've hit it there, Dwayne. It's again, the issue is, have you changed what caused it in the first place by giving by giving glucagon? And the answer is no. I mean, the reason that they became hypoglycemic is they have the medications on board. Most of the time that's the case. By giving them glucagon, all you're doing is assisting the body's ability to compensate. But the body obviously got into trouble, or the person got into trouble by being unable to compensate with their own glucagon. And so the question becomes, did you give enough glucagon, and will it be secreted over a long enough period of time to counteract the original stimulus that made the blood sugar go low in the first place? And the answer is probably not. And so it's safer in that situation, and in all of these situations when you treat someone, probably to take them to hospital and at least have them assessed there. If for no other reason, what that does is that it probably buys a couple of hours where they will be under observation and further intervention can occur. Now, it's possible certainly to leave a person with a responsible adult, but again, it just increases the risk.
Great, so I think that that concludes the bulk of the presentation. So if anyone has any questions, feel free to type them in the question box, or if you'd like to ask one live, click on the hand icon, and I'll notice that you put your hand up, and I can unmute you, and you can ask questions live that way. While we're waiting for more questions, I do have one, and Dawn, this is probably best answered by you again. The question is, why does a viral infection, for example, a cold or a flu, cause such a dramatic change in a patient's blood sugar?
Again, good question. I'm not sure that I know exactly the answer to it, although, I mean, generally speaking, what happens is that when someone is under any kind of stress, they start to release cortisol, which is essentially the steroids, which are part of the body's general stress response. So you see the same situation with people who are put on prednisone. Their blood sugars will be maybe very well maintained under normal conditions. They're put on prednisone. It increases the blood sugar, again, as part of the metabolic actions of it. And so I think the answer to the question is that as part of your body's reaction to the stress of again, trying to maintain equilibrium, this is a side effect of the the stress response.
Great, thanks, Don. I do have another question here, probably best answered by Dwayne. I'll put Dwayne on the spot. So can we just quickly review the ACP directives for D50 administration for peds under 2?
Okay. Yep. Okay, so when we look at the pediatrics, so you have 2 categories, birth to 30 days, okay, so your neonates, or your basically 31 days up to 2 years of age. So we'll talk about the neonates. The neonates, there's different ways of drawing out of the syringe, diluting the dextrose down, but you want to get it down to 10% dextrose. Whatever method you choose, how to do that, the actual mechanics of that, everybody's been taught different ways throughout their preceptorships and whatnot, but the main thing remains with the neonates. So birth to 30 days, blood sugar is less than 3 millimoles per liter. You want to get that down to 10% dextrose. And then you're going to give 0.2 grams, which would generally work out to 2 mLs per kilogram for your neonates. And now your infants, so essentially from 31 days up to 2 years of age, what you will do is you'll get that dextrose down to 25%. And whatever way you choose to, whatever way you were trained, however you get it down, that's fine. And then for them, it still works out to 0.5 grams per kilo, okay, but you're going to be giving 2 mLs, 2 milliliters per kilogram of body weight. So, so just to recap, neonates from birth to 30 days, 10% dextrose, 0.2 grams per kilo, which works out to 2 mLs per kilogram. And then for your infants, young children from 31 days up to 2 years of age, just under 2 years of age, you would give 0.5 grams per kilo of 25% dextrose, which works out to 2 mLs per kilogram. I hope that answers your question, but that is the dosing, that is our directive we have at this point in time.
Great, thanks, Dwayne. So Tracy's gone and thrown the references up for the presentation, so thank you for doing that, Tracy. It doesn't look like we have any other questions at this point, so we'll go ahead and conclude the presentation. Once again, thank you to everyone for attending. I hope you have a great Halloween, and keep your eyes posted for webinar presentations in November. We're looking at a DNR presentation as well as one on difficult IVs, so keep an eye on your emails for that notice. Thank you once again for attending, and we'll see you next time.